Dr. Shreyas, and very good morning to all of you. First day of a meeting. It's a wonderful course, been part of it for some time in different formats. My talk today is newer insight into Aetiopathogenesis of Keratconus. I'll try to keep it as clinical relevant as possible. This is what I'm going to speak today. We look at the immune mechanisms, the biochemical alterations, the hormonal, cellular homeostasis, and structural alterations. I wish to keep it as clinical relevant as possible, which can be clinically translated. You can translate to your clinic as early as when you go back on Monday. This is a paper we published with my ex-fellow Dr. Vaitesh, who is in New York now. We looked at all the multiple pathogenic factors in pathway of Keratconus. To create this pathway, it took close to 12 years. We started off with allergy as one of the factors, as eye rubbing in 2009. And over time, we built a complete list of things, starting with inflammation, hormones, vitamin D, cellular homeostasis, chemical alterations, like it looks at metabolomics, and all the also metabolic factors and how it impacts your changes in your extracellular matrix and how it can cause keratoconus. This apart from the genetic and other factors involved. So let's start with the eye allergy. When you look at an allergy or eye rubbing, the question always asked is, which comes first, the eye rubbing first or the changes happens first? I don't think in our lifetime it will be able to prove it. It's like the chicken and egg phenomenon. To understand what really happens, we have to go a little more deeper into understanding the keratoconus itself, the collagen itself. To create this, our team built our own method of examining the collagen using the polarization sensitive OCT source. A lot of you are aware of GDX. When we started glaucoma practice, GDX was a machine, then Zeiss took over. It works on the birefringence principle, exactly the same principle using the polarization part of collagen. We built this OCT, and every layer we were able to examine every layer of the collagen. And what is interesting here is that it was able to examine the collagen orientation. The darker colors are healthy. The darker colors are healthy, and the lighter colors here means the collagen fibrils are structurally oriented differently. So this changed the way we looked at the collagen, and this helped us to understand a lot of pathogenesis of this disease. One pathogenesis was the role of housekeeping mechanism of a cell called autophagy. Autophagy is how when a cell dies, it engulfed by the cell, healthy living cell, the lysozymes creates a change and it digests it. If the housekeeping is not working, then it's like a kitchen sink. If you don't clean it, it becomes dirty. And that's exactly what happens in cancer or any heart disease, and also in the eye. This is a work done by a lab when we looked at the human epithelial cells and how beautifully the cells are connecting to each other, talking to each other here. These are all the organelles, your mitochondria and all those organelles. When you create an inflammation, something similar to what you have in keratoconus, half of the time the organelles are not functioning. And these are functionless organisms. And what happens is these are all, it starts connecting to each other. It needs the support of the cell here to supply nutrients here. So this is what the cell does. And it tries for some time and then it fails. So the first translatable work we did was to see if you can improve the autophagy mechanism. And using this autophagy mechanism in cancer biology and many other places of viral biology, trehalose is a very important ingredient in creating changes in autophagy. And we tried the same thing, and then this was published in Ocular Surface, and you can see that trehalose changes the autophagy mechanism and also reduces the inflammation. So that means now you have a lot of companies, I know financial interest, any one of them, I wish I had, but you can see that all of them really changes the mechanism of this disease. How do we translate it? I just give a chance, even in a lot of my patients, when I wait and observe, I give a chance for the autophagy and inflammation to stabilize itself. One of the things I do is I give them for 6 months. It's just a lubricant with a mechanism to change. And you can see that I have just put one in the interest of time. You can see that you get, once the keratoconus stabilizes, you get a result as similar as a post crosslink. This is not a crosslink dye. You can see that there is stabilization of the cornea. The collagen has stabilized. That means that when you stabilize inflammation, when you stabilize degradation of extracellular matrix, you can stabilize the cornea like you do a cross-linking. This is a very important point, and this is what we translate. Now, is it this? You have to trust me that many more like this, but the question is, does it really work at the collagen level? This image is a beautiful image. That's why I showed the polarization OCT, because it looks at the collagen directly. This is how a normal would look. This was a patient before treatment, and this is a patient. You can see that the collagen has started showing change. And this is exactly what we see when you do a cross-linking. The collagen would show a different level of change, but here you'd probably see a change like a scarring. Here, this is no scarring. You're seeing a completely reformatting of collagen. Disclaimer, I don't have a huge data for a year, two, or many of patients studied consistently. So there are few patients which have not been able to image because of COVID, but early results show that it really changes the way the collagen. That means collagen, when you stop inflammation, it starts regenerating, and it can give you the exact same result as your cross-linking. When it comes to hormones, we worked on AI, and in the AI, this is the last stage of acceptance in the PLOS One journal. The AI of 5,000 or keratoconus picked up these 3 factors as a potential factors for progression in our patients. IgE, systemic allergy, we all know. And what was important is consistently AI picked up the model of vitamin D. So vitamin D is very important because when the vitamin D receptors, I'm not saying vitamin D free floating, it is a vitamin D receptors in your epithelial cells. Every cell which has a function of inflammation, vitamin D has its own thing. Tell me when I need to stop, because I think there's a timer there. I'll stop when it's done. When the vitamin D receptors reduces, the MMP9 grows up. That means the inflammation goes up when the receptor is down. So what does it mean? Now you know that inflammation molecules has to be treated not just by anti-inflammatory, by bringing in the vitamin D receptors to function. Why is it important? Because your collagen and all these factors of enzymes which hold the collagen are entirely driven by how the inflammation is. And this is a classic example. When there is inflammation, MMP9 here, the lysyl oxidase which binds the collagen comes down. That is one of the reasons when in the past I used to talk about cyclosporin, because cyclosporin blocks the MMP9. When you block it, your lysyl oxidase goes up. I use this a lot in my post-ectasia suspect cases. Out of, if I see, I get a lot of referrals of post-LASIK ectasias, of which not even 1% of them I do a cross-linking, because when you reduce the inflammation, the ectasia stabilizes. There are patients with 9-10 years of stabilization because post-LASIK ectasia is driven entirely by MMP9 activities. And you can see that higher the level of MMP9, this is published work, and lower level of collagen completely changes. And this can be reduced by improving LOX. LOX can go up with, it can go up as simple as Ayurvedic formulation like turmeric, but we don't know how much to take, or it can go by improving your systemic status of vitamin D, or it can go up with just a trehalose drops, which I showed you in the past. So it is important to pump up this, and this is why it is very important that this is the map I want to show again. This is a pre-treatment, post-treatment. You can see the MMP9 suddenly goes up. Just remember that Western blot graph. Once it reduces, your collagen becomes better. Now, what is the way forward? Can I have a minute or should I stop? I just 3 slides. I'm sorry for that. What's the way forward? This is the way forward. I've been talking about it for the last 10 years in a very, very hypothetical way. Now it's used in the clinic. All that what I showed can be checked in your clinic. And all the papers we published, close to 120 of them, on just the biomarkers, including my Rangachari paper in 2015, now comes in this report. Virtually, this report is going to be the game changer. This is the first report of its kind where your entire things from the tear film. Now, if this patient has an ICAM1, in a years, when you get the liftigrast, you will directly start this patient on liftigrast and not on cyclosporin. If the patient has no ICAM1 and MMP9, you will start him on directly on cyclosporin. If the patient has both of them low and something else high, and you will start on specific to that like a trehalose. And if the patient has a very high level of TNF alpha, you will treat him with cyclosporin, wait for 3 to 6 months, then do a cross-linking or a PRK. You will get probably fantastic result because TNF alpha is the culprit in most of your post-cross-linking scarring or PRK scarring. This is caught the attention of at least every company in RO and ASCRs this time, and a lot of them want to bring it to the market, and that is my aim, to bring the test at less than 1,000 rupees, which, MMP9 kit, only MMP9 one thing costs you 2,000 rupees, which is not going to work. And the future is using gene therapy, and this is the way forward. And this is my take-home point, which I have explained. You can treat the inflammation, you can treat the hormones, you can treat the metabolomics, and probably get the same results at cross-linking. I'm very, very optimistic about it. Thank you, and thank you for giving me this 1 minute extra. Thank you.
Thank you so much, sir. While we go on to the questions, I'll just request Dr. Soundarya to set up her presentation. Sir, I mean, it's always enlightening to listening to you, and this time really I felt a lot of the newer insights, like you were saying, are being brought to the clinics. So now when this is happening, sir, how does it alter the the choice of treatments which we choose for our keratoconic patients, and where does it fit into the overall algorithm? That is, when you see a patient with keratoconus now, and when do you start them on, let's say, a trehalose or an anti-inflammatory agent, whether it's right at the onset or whether it's ongoing, and what role does cross-linking have in these patients, and when does cross-linking come in?
First is cross-linking is not a treatment for keratoconus. It causes scarring.
Scarring.
So scarring or controlled scarring is what cross-linking is. Treatment of keratoconus is actually looking at the root cause. So give the patient a chance to see if they can recover in few months' time. So however thin the cornea is, I give them at least 3 to 6 months' time. So in that time, I check their vitamin D status, IgE status, and treat them with trehalose, or if there's very high level of inflammation, MMP9 on it. It's just not for your cross-linking effect, your outcome of cross-linking. For example, you go back and do analysis of eye rubbers and scarring, post cross-linking. 99% of eye rubbers will have a huge amount of scar because they have huge amount of inflammation. When you wash them off by doing all this, your cornea is so pristine clear after cross-linking that you'll be wondering why there is a difference between the two. So always give them at least 3 to 6 months. If not for stabilization, at least you will see that it will help you to build the cross-linking better.
Wonderful, sir. I mean,
most important thing, again, no financial interest. We all have a habit of writing a lot of lubricant drops. Osmoprotection is one type of drops when you give them when they're waiting. Telling them just not to scrub their eyes or doing probably will not work. Just be a little proactive and giving them something so that this changes. Biologically, this does a big, and I've shown you some results on it. And the best result was the work on polarization OCT, which shows the collagen getting stronger.
And just as a quick guideline for all of us, sir, till these tests become widely available, you were saying you would avoid cyclosporin in certain conditions when it is elevated.
At this point of time, it's very difficult because we don't know. But over time, this probably we want to bring it as early as 2023 if everything goes well. And this has to be cheaper. It has to be cheaper for the patient because we can't overload with them with the things.
Thank you so much, sir. Always great. It would be a pleasure if you could stay back